Namaskar and a very warm welcome to INASL Day 3. And after 2 days of groundbreaking presentations and thought provoking discussions, today we dive deeper into into translating into the innovations and practice. So, with deep honor, I invite on stage the chairpersons for the session Professor R.K. Dhiman sir, Director SGPJ IMS Lucknow, Dr. Baldev S. Rana, Dr. RPG MC Kangra, Dr. GP Dhakal sir, Dr. GP Dhakal sir, welcome sir, from Bhutan, and Dr. P. Rajshekhar sir from Chennai. Welcome on the stage, sir. And I request the chairpersons to initiate the session. Thank you.
Good morning, audience and distinguished speakers. A very warm welcome to this session on the complications of cirrhosis, hepatic encephalopathy. The first speaker for today's session is Dr. Brijesh C. Sharma, and he'll be speaking on minimal hepatic encephalopathy. Should it be treated or not? Sir, you have the floor.
Thank you, chairpersons. Good morning, ladies and gentlemen. I am thankful to organizers for giving me this opportunity to deliver this talk on MHE should be treated or not. Sorry, not moving. Okay. According to INASL consensus guidelines, MHE is defined as neurocognitive complications in patients with chronic liver disease and or with portosystemic shunts, which is not detected on detailed neurological examination, but associated with abnormalities with neuropsychological or neurophysiological tests. And these tests can be performed quickly in outpatients, irrespective of patient's educational status. In MHE, there are no symptoms of overt hepatic encephalopathy. There are mild cognitive and psychomotor deficits. And also, the standard neurological examination is normal. Cognitive function abnormalities include impairment of attention, speed of information, motor abnormalities, and impairment of coordination. The prevalence in cirrhosis ranges from 30 to 70%, and this different prevalence is due to varying criteria used for diagnosis. Prevalence depends on severity of liver disease, age, etiology, past history of HE, and presence of large varices. The database is ineffective because of inconsistency in coding. The question comes, it should be treated or not, but first is it clinically significant? And most of literature says, yes, it is clinically significant because it impairs health-related quality of life, driving skills, and worse natural history, poor prognosis, and a cost burden to the family and doctors and the hospital. Now, in MHE, the basic activities like shopping, dressing, and personal hygiene are preserved. However, complex activities like attention, information processing, psychomotor skills, memory, and driving are impaired. Also, sickness impact profile score is abnormal in patients with minimal hepatic encephalopathy. In a study, it was found that cirrhosis without MHE, the score was 4.6. However, with MHE, it was higher, it was 12. And this sickness impact profile score is more impaired in fields of social relationship, alertness, mobility, sleep, work, home and recreation. Now, driving skills are impaired in patients with MHE. Around 2/3 of patients are unfit to drive, both on simulated or as well as standard real roadside test. And it is found that there are abnormalities in car handling, adaptation, and cautious maneuvering in patients with MHE as compared to cirrhotics without MHE. Now, patients with cirrhotic patients having higher rates of traffic violations and accidents compared to healthy controls. And patients with MHE had the higher rates of traffic violations and accidents as compared to cirrhotics without MHE. So it is found that MHE is a sole risk factor for traffic violations and accidents. The next, in natural history, the questions come, does it predict development of overt HE, or is it associated with poor prognosis, that is increased mortality? Now, follow-up over 5 months has shown that persistence of MHE can be seen in three-fourths of patients, and worsening in 10 to 40%, development of overt hepatic encephalopathy around in 1/4 of patients, and mortality in patients with MHE is 15% as compared to 11% without MHE. And this shows the follow-up of around 5 years, patients with minimal hepatic encephalopathy had 30% mortality as compared to patients without MHE had 30% mortality as compared to patients with MHE, that was 84%. And also 11% of patients without MHE had mortality over 1.5 years as compared to 35% of patients with MHE. Now, also patients with MHE have an economic burden. There is substantial cost involved as a result of diminished work performance and lost wages in patients with MHE. Around half of patients with MHE do not have regular employment compared to only 15% of patients without MHE. Another half of patients with MHE were found unfit to work. Now, there was a survey conducted by ASLD among physicians, gastroenterologists, and hepatologists. First question was, is MHE a significant problem? Most of physicians, gastroenterologists, and hepatologists knew that it is a significant problem. However, 16% say no, it is not clinically significant. And should MHE be tested? 3/4 of physicians, gastroenterologists, and hepatologists said yes, it should be tested. And this survey concluded that MHE is a clinically significant disorder that impairs health-related quality of life, predicts development of overt encephalopathy, and is associated with poor prognosis. There was a survey conducted by Dr. Parveen in Gangaram Hospital in India over 700 centers, and 700 total physicians, gastroenterologists, and non-gastroenterologists were sent a questionnaire. Of them, 75% responded, and 3/4 of total were aware of what MHE is. And this was more commonly seen in gastroenterologists as compared to non-gastroenterologists. And around 88% of these said that the MHE should be tested in all cirrhotics, and this was also more commonly seen with gastroenterologists and non-gastroenterologists. And most of the physicians, they did not test for MHE or tested for less than 10% of their patients. However, gastroenterologists usually tested their patients for MHE. Quality of life parameters, that does it impair quality of life or lead to development of overt HE or is associated with poor driving skills. These factors were equally known to physicians among gastroenterologists and non-gastroenterologists. And most common test used in India was a paper pencil test. And most of physicians who were not testing it, they said they did not have time to test for it in OPDs, therefore they skip over this. And most of the physicians among gastroenterologists, hepatologists, they are treating with lactulose, rifaximin, L-ornithine, L-aspartate, probiotics, and combination of 2 or more drugs. Now, treatment modalities which have been used are lactulose, rifaximin, probiotics, L-ornithine, L-aspartate, and nutrition. However, many physicians, gastroenterologists, and hepatologists know that it is a significant clinical problem, and even then they do not test and they do not treat. There is another school of thought among these physicians that MHE is present in more than 70 to 80% of decompensated cirrhosis. So why to test that? Why to waste time on testing? Straightway treat them with anti-encephalopathic measures. And also, there are other school of thought that patients, because it is as clinically significant, poor significance, and is associated with quite frequently development of oval touchy, so therefore test them and treat them. Do not teach the patients who do not have MHE. In this landmark study, Dr. Dhiman from India, the first randomized controlled trial which evaluated impact of lactulose therapy on minimal hepatic encephalopathy. And they found that of 30 patients, 3 months treatment with lactulose, only 2 patients did not respond, 28 patients responded to this therapy, as compared to around 30% of patients, that is 20 out of 30, persisted with minimal hepatic encephalopathy. And same Dr. Dhiman's study, in patients who were not treated with lactulose, there was no improvement in health-related quality of life. However, patients treated with lactulose had marked improvement in sickness impact profile score and health-related quality of life, especially in fields of social relationship, alertness, emotional behavior, ambulation, recreation, and total sickness impact profile score. Then this study conducted by Dr. Praveen, GB Pant Hospital, the randomized, the study Dr. Bajaj, he evaluated probiotics in form of yogurt for treatment of MHE. Yogurt coagulated milk product results from fermentation of lactic acid in milk by Lactobacilli bulgaricus and Streptococcus thermophilus. They took 25 patients of MHE. Of them, 18 patients were treated with yogurt for 2 months. 8 patients did not receive any treatment. At baseline MHE in all the 25 patients. However, patients who were treated with yogurt, MHE reversed in all the in 3/4 of patients. Patients who were not treated, there was no improvement in MHE. And prevention of OHE was seen in all the patients treated with yogurt over 2 months, as compared to 1/4 of patients with MHE who were not treated. They developed oval touchy over 4 months, over a 2 months period. This study from GB Pant Hospital, conducted by Dr. Praveen, this was a randomized controlled trial comparing efficacy of lactulose, probiotics, L-ornithine aspartate, and no treatment. Duration of treatment was 3 months, and what we found that lactulose, probiotics, and L-ornithine aspartate in 3 groups with 3 months treatment, reversal of MHE was seen in 1/3 to 1/2 of the patients. However, there was no significant difference in results. But reversal seen in all 3 treatment groups was significantly higher than no treatment group. Similarly, ammonia reduction in all 3 treatment groups, but not in no treatment group. Delta, that is percent change in reduction of ammonia, was equal but higher in treatment groups as compared to no treatment group. And it was seen that health-related quality of life improved in all the 3 treatment groups and correlated with reversal of MHE. And this is a study evaluating role of rifaximin in treatment of MHE done from DMC Ludhiana. With 2 weeks therapy, one half of patients reversed as compared to 18% of patients with placebo group, and in 8 weeks therapy, 3/4 of patients treated with rifaximin reversed as compared to 1/5 of patients not treated with rifaximin. And it was found that with treatment of rifaximin, there was improvement in driving skills, driving errors diminished, and there was significant reduction in percentage of total driving errors in rifaximin group as compared to placebo group. This was another trial which compared lactulose versus rifaximin, open label randomized controlled trial for 3 months, and it was found that reversal of MHE, overall prevention of overt HE, and improvement in sickness impact profile scores were equal in both the groups. They were significant but equal in the both groups. This study performed by Dr. Sudhir Maharshi from GV Pant Hospital again, a randomized controlled trial comparing nutritional therapy versus non-nutritional therapy.
Dr. Sharma, I think you can speed up.
Yeah, I'll just in patients with MHE. And it was found that with nutritional therapy, MHE improved in around 3/4 of patients, as compared to 1/3 of patients without nutritional therapy. And also, higher prevention rate of overt HE, less hospitalizations, and less mortality in nutritional group as compared to non-nutritional group. Health-related quality of life and sickness impact profile score also improved with nutritional therapy as compared to non-nutritional therapy. And with nutritional therapy, we need to treat 5 patients to prevent 1 episode of overt HE, as compared to 31% of patients without MHE to prevent 1 episode of overt encephalopathy. Now, I will just take 2 minutes, sir. The economic or cost effectiveness of treatment has been evaluated, and 5 management strategies were employed. Presumptive treatment of all cirrhotics for MHE, diagnosis by neuropsychological examination with treatment, diagnosis by standard psychometric examination with treatment, diagnosis by rapid screening using inhibitory control test with treatment, and no MHE diagnosis and no treatment of MHE. And it was found that in patients with lactulose treatment, testing by ICT, inhibitory control test, and treatment with lactulose were the most cost effective and cost saving in this group. Treatment with rifaximin, testing with inhibitory control test and treatment with rifaximin was cost effective but not cost saving. Now, coming to algorithm, whenever patient claims stable cirrhosis without overt HE, normal user examination, we must perform psychometry tests, at least 2 tests, number connection test or figure connection test, in addition block design test, Z symbol test, or critical figure frequency. If scores are normal, retest after 6 months, no MHE. If abnormal, diagnosis is established and we should treat the patient. So to summarize, ladies and gentlemen, MHE, at least with today's literature, it has been proved that it is a clinically significant disorder. It impairs health-related quality of life, driving skills, sleep, and memory. It is associated with higher rate of development of overt encephalopathy, poor prognosis, and is economic burden on society. Treatment of MHE improves cognitive functions, health-related quality of life, sleep, and driving skills. And it also prevents development of overt encephalopathy, improves survival, and also decreases economic burden on society. Thank you, ladies and gentlemen, for your kind attention, please.
We'll save the question after the second presentations.
The next presentation.
Shall I sit here?
The next presentation. Dr. Patrick Kamath on variations in survival by MELD subtypes and cirrhosis. Are all the models the same?
Yeah.
Over to Dr. Patrick Kamath.
Thank you very much again for inviting me. And my topic is variation in survival by MELD subtypes. Are all models same? I'll start with the conclusion and the take-home messages. Use the original MELD score for most patients because it's been most validated. So this would be for selection of patients for TIPS, alcohol-associated hepatitis, selection for surgery, and for prediction of hepatic decompensation. For prioritizing patients for transplant, there's the MELD sodium and the MELD 3.0. I'll go over that in a little more detail. And I think in the future it's going to be MELD from synthetic data, and I'll spend a little time towards the end on discussing what synthetic data is. So the first question is, why do we need prognostic scores? You'll see multiple scores coming around. So when you create a score, you have to ask the question, why are we using it? You can use it as a clinical tool. So that is to counsel patients to make some management decision to optimize care. And so generally my suggestion would be to use the original MELD score. You can use it as a research tool. That's for entry criteria. Use it as a surrogate endpoint and to stratify patients, say according to MELD score. And then as a policy tool, that is, in the US, it is going to be for allocation of livers, and currently it is 3.0. So when you use a model, two questions: how do you determine accuracy of the model, and what do you mean by accuracy? Two aspects: discrimination, which means ranking patients at higher risk for mortality. Generally, it means a person at a high number is at a higher risk for mortality than the lower number. And you determine that by the C statistic. So if we say C statistic is 0.8, it means 8 out of 10 times the person with a higher score will die before the person with a lower score. So if you take two pairs, so who will die first? And so in transplant populations, all three MELD versions have been compared. So my question was, which of these should we really use? So all three have been compared. Calibration is about the individual patient. When will the individual patient die? So that is, or at least has not been validated across all scores. All these take time, so it's the original one. And towards the end, when I talk about synthetic data, I'll talk about how we'd rather spend time calibrating using synthetic data. So when you're using it for individual patient, you can take this down. I'm not trying to sell this site. It is free. As long as I have any control over this, it will be free for anyone to use. So we have different types of patients you can actually use this in. So for instance, let's take a patient with TIPS. You're going ahead for TIPS. So you click on this, you enter the bilirubin, creatinine, INR, type of liver disease, and we calculate. So we'll tell the patient, this is your risk of mortality. Patient, family, and you can decide whether to go ahead with the procedure or not. For alcohol-associated hepatitis, currently is used probably the most widely. So again, here we take a patient, we can get 90-day mortality. So creatinine of 2, bilirubin 15, INR 1.8. There's a MELD score of 30. We know this person has a 62% mortality at 90 days. How useful is it in alcohol-associated hepatitis? This is the global study that has been a little over 2,000 patients. And what were the conclusions? MELD was superior to the Madrid discriminant function. The conclusion from that study was Madrid, and I'm showing you data, was actually quite inferior to the other studies. And the MELD score had the best performance in predicting short-term mortality. So here are the data in those patients looking at 28-day mortality. MDF is the Madrid discriminant function. So 28 days, MELD and MELD sodium about the same, turned out the best. And if you look at 90-day mortality, which is the endpoint for studies, so MELD and MELD sodium, and because there's calibration available for MELD, the decision has been made that MELD will be used and not MELD sodium. Now, Alex Louvet is here. So he and Philippe Mathurin created the Lille score. And so this is really a nice paper from Alex, published about 9 or 10 years ago. So you can use this to determine what the prognosis of the patient is going to be. So let's say here is a MELD score of 21, that is here. And this patient has a Lille score of 0.45, so that's at 7 days. So what is the risk of mortality in this patient? You can see somewhere between 10 and 20%, and so this is 15%. So use the baseline MELD and the Lille score to determine prognosis. And for instance, the 6-month mortality in these patients is in the lower graph, and so this is at 24%. So how are we recommending that this be used? To determine severity of AH, at admission MELD score, response to treatment, Lille score, and to determine long-term is going to be a combination of the MELD and Lille score. When it comes to stratification for studies, what score do you use to study? So mild is low mortality, less 10 or less, moderate is 11 to 20, and severe is 21 or greater. And so if you're doing a study and you're including mild or moderate patients, then mortality is probably not an endpoint because mortality risk is lower in those patients. And 21 has been confirmed in several of the NIH studies, and that's what's being used for future NIH studies too. Selection for surgery, how do you use this? Again, you can go to our calculator. Let's say 75-year-old patient with ASA 4, bilirubin 5, creatinine 2, INR 1.5, viral disease. This is an extremely high risk of mortality. So try conservative measures in these patients if it's elective surgery. For hepatic decompensation, we don't have a very good score. So currently, we know there's no accurate score to predict mortality in compensated cirrhosis, but serum albumin, HVPG, and MELD score are good predictors of hepatic decompensation. Now, transplant prioritization, that's where MELD sodium and MELD 3.0 come. And why are these changes being made? When liver transplant came about, there were plenty of organs available, but only few patients because not many people wanted to transplant them. But as surgeons became familiar with transplant, more and more people wanted to transplant patients, but then the organs were limited. So you had to come up with a priority system. So the first UNOS priority system came up as the CTP score, but since the score was equal, that's A, B, or C in many patients, so then you use waiting time for transplant. And there were many problems with that. So that was changed to urgency status, how urgent, which patient is at the highest risk of dying. And that's when the MELD score came in. But then again, there were some problems with the MELD score, as I'll show you. And so that's why there's constant move to refine these scores. So what was the impact? So when it was changed, we want to make sure there was a system where everyone had equal access to transplant. So you can see green is pre-MELD, death in Black populations versus white, or African American versus white. So 1.51 means more African Americans or Black populations were dying. They were dying much more than white populations. But post-MELD, you can see it's 0.96. So equal rate of death as white populations. In fact, they had a slightly better rate of transplant than white population. So it actually helped racial discrimination. The problem was, because creatinine is involved in here, death in females actually increased. So as compared to men, more women died on the wait list and fewer were transplanted. So things had to change. And that really took a long time in a male-dominated transplant society. It really took a long time for us to try and get the change. So ultimately, I won't go over MELD sodium. That also had some problems, but now MELD 3.0 we hope will take care of these changes. And MELD 3.0 is slightly better than the MELD sodium. And for the sodium and the MELD 3.0, I take very little credit for this. It's my former fellow and my colleague and friend, Ray Kim, who has done all this work. So we've included albumin. Gender is important here, so women get a slightly higher range, and we hope this will equalize things across women. The problem is the future. None of these are perfect. We're looking at whole groups of patients with a certain score and saying, this is the risk in the individual patient. That doesn't make sense. So now we are trying to use synthetic data. Again, I've got a super brilliant fellow, Joseph Ahn, who's going to join us on staff very soon. So synthetic data is you take the data, and I'm going to show you how you do it, and then use an algorithm to create another set of data which looks identical to the original data, but is completely de-identified. And it has some benefits which we can discuss later. So this is how synthetic data works. Look in the top column. This is a dog. And you keep adding noise. So you have a digital picture of the dog, and you keep adding noise. So it's called noising and denoising. So you keep adding noise until completely the data you get is purely noise. But you know what you did to create noise. So then once you get noise, you do what's called denoising. Remove all the noise, and you come up with a dog. You can see the dog is another dog, has all the characteristics of the dog, but is not the identical dog. So this is what is called synthetic data. So we looked at the 38,000 UNOS cohort, and a synthetic data of 38,000, you can see is almost identical. It'll never be identical because it's synthetic. You know, when you add the noise and you remove it, it's not that. But you can see it's almost identical. If you look at the individual characteristics, almost identical. If you look at the survival patterns, almost identical. The median transplant survival in the regular cohort was 110 days. In the synthetic cohort is 101 days. And transplant free is 22.2 and 22.8. So we think this is a very accurate representation. MELD performance, very good. But here is the advantage. Now we can pick the individual. So let's say Rajiv Jalana and I have the same score. Our survival is going to be different. He's muscular, 0% body fat, as compared with me. We know his survival will be better. So you cannot use a model based on an older person and apply it to a younger person. But now from the synthetic data, we can apply it to the individual patient. So we're going to be able, we hope, to say this is the outcome of an individual patient. So take-home messages again, pick the score based on the population you're applying it to. Use the MELD score for most patients. But when it comes to transplant prioritization, it's currently 3.0, and I think in the future we're going to be using synthetic data. Thank you.
Questions at the end, actually.
Okay. So for the next, we are having all the questions in the end of the session. Now we are having a debate on ammonia in cirrhosis. So valuable biomarker are just... Okay. Okay, sir. Though... Okay, so okay. So now after these two sessions, the house is open for the discussions for these two sessions.
Hello, sir. My question is to Dr. Brajesh. Sir, so you told about so many therapies that can be given for MHE. I just wanted to know, like, for how long these therapies need to be given, and for how long do the patients remain in remission without any MHE? And what if the patients again develop MHE? Are we going to treat them again and again with the same therapy? Or are we going to refer them for a liver transplantation? Because HE remains as an indication for liver transplantation.
Patient with MHE and start your treatment. Which is my. If patient has MHE and is started on treatment, it is not to be stopped. It continues lifelong. And what was the other query you want to ask?
So basically, it has already been answered. So basically, I was asking for how long the patient can remain in remission with that.
It is not to be stopped. Because whenever you stop it, the MHE part will recur, and it again all the risks like development of old HE, higher mortality, and all the driving skills impaired and everything will reappear. Therefore, not to be stopped.
So in such a scenario, the patient might not develop overt HE ever. So in such a scenario, when will the indication for a liver transplantation come for such a patient? Because the patient has
that we goes according to MELD score. Whenever MELD is high, this thing. And for this thing, MHE, if one survey we did in India, they give decompensated cirrhosis, child C, they give lactulose to every patient. And when we asked, you know that MHE is very common, you are giving lactulose to treat all patients with MHE or decompensated cirrhosis? They said no. We are giving them to prevent first episode of encephalopathy. Not to prevent MHE, but to prevent first episode of encephalopathy, that means primary prophylaxis. That was their this thing.
Okay, sir. Thank you.
Thank you. To amazing talk. So one question for Professor Sharma and one for Professor Kamath. So my big question for MHE is the specificity of the test that you use. The specificity of the test we use to diagnose MHE, and what component of those tests reflect encephalopathy and what reflects cirrhosis. And so I think we need to start to thinking about what are we measuring with these tests.
This issue has been very well discussed, and after discussion and also based on data available, it was concluded in 1998 in Vienna, World Congress, that the best test carrying specificity more than 80% is psychometric hepatic encephalopathy score. At that time, the Stroop test, inhibitor control test, animal lambing test, these were not available. So this neuropsychiatric simple psychometric hepatic encephalopathy score, sensitivity more than 90%, specificity more than 80%. So therefore, this test is gold standard. And as compared with this test as gold standard, Stroop test, ICT, and animal lambing test has specificity around 70%.
Thank you. If I may come to Patrick, so where is AI-based algorithms going to be in terms of organ? No, this is for Patrick. For Patrick.
Okay.
So where are AI-based algorithms go? How far are we away from generating that sort of information?
So if I can just add on something to that answer. So I'm actually very careful about even testing for minimal hepatic encephalopathy, because I don't know what the perfect test is. One, I look for sleep apnea, depression. Those are simple things which look like that. Because the moment you make a diagnosis of hepatic encephalopathy, it doesn't matter what you call it, they cannot drive.
Yeah.
It changes a lot, occupation. So I'm very careful about that. Coming back into this, it's going to be a little slower now, the digital application. Remember, 3.0 has just changed to that. They still don't know how that's going to work out. All the computers had to be changed. There is right now no appetite to change it even further. So we're just doing background work right now. But we hope that for the individual patient, and that's where ACLF and everything will come, selection patients better. So protoplasm, whatever's in the database, if it's not in the database, we cannot check. But once we have the digital twin, that would work. And for Alex, so a big move right now is not in transplant for digital, it's to get a cohort of patients with alcohol-related hepatitis who are the so-called digital twins, so that we hope in future AH trials, we don't need a control group. Because there's always this fight of what should be the control group. So we'll have a treatment group to compare, and the FDA believes that this might be better than the control groups that we actually have in there, and patients don't want to go into control groups. So it'll be a little time, Rajiv. It's going to take time. People need to feel the need to change. And when you say synthetic data, most people say, oh, they're making up data. So that's the problem with the term too.
In the interest of our time, we can have just 2 short questions, one on this side.
Okay, so thank you. My question to Dr. B.C. Sharma, an extension basically of the last 2 queries. Do we really know the natural history of minimal hepatic encephalopathy, whereby meaning that if I have today minimal hepatic encephalopathy, I'll be in MHE for the next 7 days, 1 month, 2 months, because we use the terms like reversal of minimal hepatic encephalopathy, while if a person is in grade 2, he is out of encephalopathy, say in 2 days. But when we talk of MHE, we look at him at one time point and then another time point 2 months back, saying that he's reversed in 2 months. So we really know on serial testing that if he is in MHE today, he is going to be in MHE for the next 2 weeks, 4 weeks, 1 year, forever. So do we have any such data?
Yes, we have this good data available. Your question has 2 parts. MHE patients, I showed this data actually, no treatment group, placebo group. MHE part improved in 10 to 20%, and some studies maximum 30% spontaneously, without no treatment group and placebo groups also. So that is the natural history of MHE untreated. However, 30% of patients who improved may develop MHE again. So it's not a clear-cut this thing. Second question you asked, grade 2 encephalopathy, this thing. Well-known phenomena, after patient improves with overt hepatic encephalopathy, he can have all the features of MHE, cognitive function impairment and all that. There are 4 studies in that. One is our study, published in Neurology India, then Dr. Bajaj in gastroenterology, Dr. Dhiman in American Journal of Gastroenterology, and Amodio in General Hepatology. Ours was the first study, and following that, these studies come same results. Post-encephalopathy, if patient have features of MHE, more poor prognosis than patient who had only MHE initially.
Thank you.
Thank you, sir. So if in the interest of time, we move on to the next talk. So then now the next talk is the debate on ammonia in cirrhosis. Is a valuable biomarker or just a misleading metric? To in the favor is ammonia is a useful biomarker in cirrhosis, and to present is we have Dr. Rajiv Jalan. He needs no introduction to this gathering. Sir, please.
Well, thank you very much for this kind invitation and this terrific topic to discuss today. Can I have my first slide? So here are my disclosures, none of which is really relevant to what I'm going to talk in this meeting today. So when I was asked to sort of talk to this topic, I thought a little bit to myself as to, what is the importance of ammonia in the development of hepatic encephalopathy? So this slide really shows the mechanisms underlying the development of hepatic encephalopathy. And whether you consider the factors that are associated with systemic factors that are in the circulation, or factors that are actually existing inside the brain, almost each mechanism that has been proposed as development of hepatic encephalopathy is actually directly linked to ammonia levels. So therefore, it is inconceivable that you would get hepatic encephalopathy in the absence of hyperammonemia. So pathophysiologically, it's particularly relevant. And so this slide actually is not for you to read, but I asked myself that there are so many data out there that evaluates the role of ammonia. And so therefore, why are we actually having this debate at all? And the debate really relates to the fact that we have opinions, opinions, and opinions, as opposed to the data. And look what are being expressed by very senior hepatologists in current journals. So serum ammonia testing has not had consistent benefit in clinical diagnosis. The next step is de-implementation, providing real-time decision support. The arc of ammonia's history in the management of overt HE has bent towards irrelevance. Ammonia cannot diagnose HE, whereas low ammonia cannot exclude HE. Serum ammonia testing provides, so therefore there is this huge amount of rhetoric that these senior hepatologists in big journals are writing. And therefore, what we as a community really need to think is how are we going to get beyond this whole perspective, which is an expression of people's views as opposed to data. So we are in India, and when things are not great, we go to the temple. And so that's what we did. So ammonia is actually linked with, is named after an Egyptian god called Amun. He's an Egyptian god that looks after a cesspool of urine to protect the community from the effects of ammonia, which is produced from. So we created a new consortium. We called it the Ammon Consortium, after the god which is supposed to represent ammonia. And the idea of this really was this consortium, this group, which is a loose group, was to evaluate the role of ammonia in patients with liver disease to find out as to whether there is any role for ammonia in the diagnosis. Is ammonia important in overt HE? Is important for the diagnosis? Is important, the ammonia levels correlate with severity of encephalopathy? Does a change in ammonia level predict the resolution of HE? In outpatients with cirrhosis, do ammonia levels predict the risk of development of OHE? We heard a little bit about it earlier. And then to see as to whether we could create new models, and Patrick has spoken about the models really nicely. So is it possible that we are missing a key biomarker that will improve prognostic models? So this is what we set out to do about 3 or 4 years ago in response to this rhetoric of many of us very senior colleagues who rubbished the importance of ammonia as a potential biomarker. So let's look at what we have out there. So here are the INASL practice guidelines in relation to the diagnosis of HE. So it's very clear, it's a strong recommendation. And this strong recommendation is based upon these 4 published papers, which includes more than 1,000 patients. So in patients with delirium, encephalopathy, liver disease, ammonia measurement should be performed as a normal value brings seriously. So therefore, for diagnosis, we need ammonia levels. What about whether it's a predictor of outcome in patients with cirrhosis? And these are data from Dr. Shalimar when we did a study together that in the cirrhotics with acute decompensation and OHE, if your ammonia levels are greater than 79, the risk of death is significantly greater compared with those that have low ammonia levels. So Dr. Shalimar is not the only one in the room, but there are over 3,000 global patients in whom such data has been generated that ammonia is prognostically important. Let's consider whether change in ammonia makes a difference. And this is data again from Dr. Shalimar, where he shows that the percent mortality of a patient with OHE increases. If ammonia increases, mortality increases. If it's unchanged, mortality is high. But if you reduce ammonia within the first 3 or 4 days, there is a significant reduction in the risk of death and the wake up from ammonia levels. So it's very clear that a change in ammonia levels measured on the day 1 and within the first 5 days is associated with reduction in mortality. And again, he's not alone. We have Dr. Verma here, Nipun, 3,000 patients in the ARC database showing exactly the same thing. So 3,000, more than 5,000 global patients that you need to measure, not ammonia once, we measure it twice, it helps prognosis. What about outpatients? And this was really the critical contention, because a lot of people talk about acutely decompensated patients as being complex. What about in the outpatient cohort? And these are data that was generated within three groups in the UK and Spain. And what we did here was to look to see as to whether we could measure ammonia levels in a stable patient in cirrhosis, and as to whether that would predict the risk of mortality and complications and encephalopathy. And what we found was a critical level of 1.4 times the upper limit of normal that was able to define not only the occurrence of overt hepatic encephalopathy, but also we observed all liver-related complications, as you can see, survival, and then in the large validation cohort, we observed the same thing. And as you would have it, according to God's gift or God's blessing, a paper appeared nearly 6 months after that showing exactly the same result in 500 patients. So outpatients, it can tell you what is going to happen to your patient. But of course, as we know, cirrhosis is complex. And so therefore, in order to improve whether ammonia would add to other variables and whether we could improve the predictive ability of ammonia, we said we're going to use it as a covariate in many analyses. The first question was really, can Ammon OHE, which I'll show you in a minute how we built it, it's a machine learning algorithm, predict what happens to outpatients, whether we can use it in patients undergoing TIPS. We heard from Patrick about the MELD score. Ammon OHE, can it predict the risk of development of any liver-related complication in a patient in the community? And finally, whether it can tell you which patient who is admitted to the hospital with no HE will develop an episode of acute decompensation. So we published this a few years ago, the first model, and this was really a machine learning algorithm which is based around 1,500 patients. So we wanted to develop a new prognostic model, and we did it using about 426 patients who were followed up. These patients also we heard about FES, we had heard CFF. We wanted to compare how it works against the standard neuropsychological tests. And the idea was whether this would predict the occurrence of first encephalopathy episode. And then we tested it in 2 other independent cohorts, as you can see, from Vienna and from King's. This is what we found, that it functioned. So as you can see here, it is a score which includes albumin, creatinine, ammonia upper limit of normal, sex, and the presence or the absence of diabetes. And as you can see here, we heard about C-index, 0.844. And it performs better than FES and CFF in the prediction of risk of overt hepatic encephalopathy. So an algorithm incorporating ammonia that tells you the risk of hepatic encephalopathy. And this just shows you whether it can tell you about all liver-related events. And these are all papers that are either published or in publication. As you can see here, that Ammon OHE model performs the best compared with Pew, MELD sodium, MELD 3.0, in terms of any complication and mortality of the cirrhotic patient, as you can see here. It's not 5, 10, 20, 50 patients, which we saw in the MHE studies. This is 1,500 patients in this particular study. What about TIPS, which is, of course, a very important, encephalopathy is a very important complication. And as you can see here, we had nearly 600 patients in this study. We are in the process of validating this, but these are the independent predictors of occurrence of the first episode of hepatic encephalopathy after TIPS insertion. As you can see, ammonia upper limit of normal is a very important predictor of development of hepatic encephalopathy, and we just received data from Rocky, nearly 600 patients. We're trying to validate this. So does it fulfill criteria? The Cox postulates, as you know, helps you define the importance of any variable. So yeah, it must be identified in all individuals affected by the disease. I've shown you that it's important for the diagnosis. Can it be isolated? Can be isolated from the disease individuals? Yes. Can it be introduced into susceptible individuals and cause the disease? And this data I've not shown you, but very nice data from several groups showing that if you induce hyperammonemia, these patients become encephalopathic. If you restore its levels, and we heard about lactulose, rifaximin, ornithine aspartate, etc. If you reduce levels of ammonia, patients wake up. So I think it really is very clear to me that there is incontrovertible evidence that ammonia is an important biomarker. It helps you diagnose the condition, to use it for response, to predict what's going to happen to patients, to define safety. Susceptibility is a risk biomarker, as I've shown you. It's diagnostic, and it's useful for monitoring. And I'm very happy to tell you today that there is a very large Delphi consensus being drawn up by the Asian Society, who's going to produce new guidelines to re-reflect and define the role of ammonia as a biomarker in patients with cirrhosis. So with that, thank you very much, and I'm happy to take questions at the end.
So to speak on the other side, ammonia is unreliable and non-specific biomarker. We have Dr. Akash Shukla. Sir, please.
Good afternoon, everybody. Thank you, Professor Jalan, for the lovely introduction. You almost convinced me there. And I almost thought of throwing in the towel. It was really intriguing, amazing, and you know how well you misguided everybody. So it was you ended up talking about ammonia being a target, and there's no debate on it being a target. The debate is whether it is a good biomarker or not. So debating with Professor Jalan on ammonia, when I got the topic, this is what I felt. I thought that there's absolutely no chance. And this almost got confirmed when I came to know that 2 speakers before me were invited for this and who had dropped out. So I was a third choice. But anyways, I thought let's go with the flow. So why is ammonia done in patients with cirrhosis? For diagnosis and staging, for assessing response to treatment in patients with HE, for prognostication, and in clinical trials for various reasons. And we are all familiar with the Trojan horse hypothesis. And do you think it is really always true? The answer is, as a therapeutic target, probably yes. But as a biomarker, let's see what the data says. So this was a study which demonstrated that ammonia increased with severity of hepatic encephalopathy. I mean, this is so obvious when you look at the statistics. But when you look at the graphs closely, you find that there are so many overlapping values. Just look at grade 1, grade 2, and grade 0. Very few outliers, which is what made this study significant. So huge overlapping values in different stages of encephalopathy. In fact, 69% of patients without HE had elevated levels of ammonia in this study. And based on this study, it was concluded that serum ammonia cannot be used to rule out HE, but in severe HE, grade 3 or 4, a normal value should question the initial diagnosis of HE. So this was a meta-analysis published in PLOS One last year. Correlation of ammonia and blood laboratory parameters with HE, 31 studies, 2,700 participants. The mean ammonia level in HE group was 127 versus 92 in patients without HE. But when you looked at patients with or without covert HE, it was the same. The forest plot showed a significant increase in the mean difference of ammonia levels in HE compared to the control, but no correlation with the severity of HE. In fact, if you look at the meta-analysis in details, it found that it was the high creatinine, low albumin, low sodium, which had a far more stronger correlation with HE as compared to no HE. Not only this, these were indicators for progression of HE and associated with higher inpatient mortality, and which is what Professor Kamath also has shown consistently in various studies. You look at this study showing very similar. the plasma ammonia levels, whether it's grade 0, grade 1, grade 2, very similar. Only in grade 3 you start seeing few outliers. Now, a study published by Professor Shawcross, this is published in 2011. It was infection and systemic inflammation, but not ammonia levels were associated with grade 3, 4 hepatic encephalopathy. So you see the arterial ammonia levels, not very different between the survivors and the non-survivors. So again, not a very good predictor of mortality. Paper from Don Rocky's group, plasma ammonia levels do not guide clinical management of patients with hepatic encephalopathy caused by cirrhosis, published in AMJ 2020, did not show any difference in the ammonia levels between the two groups. Yes, it did show us increased mortality in those who had normal ammonia levels. The same study talked about resolution of MHE. So whether you measure the ammonia levels or you don't measure the ammonia levels, the outcome is the same. When you measure the ammonia levels, whether it is high or normal, the outcome is the same. So then, is it really a good prognostic marker? I think that's another point too, I think beyond doubt. Now, this is another very interesting study, which was on reversal of diuretic-induced hepatic encephalopathy with infusion of albumin but not colloid. It showed that if you give albumin, but they improve the HE at 24 hours and it's sustained at 72 hours. But if you give colloid, it does not improve. But in both the groups, there was an improvement in the ammonia level, improvement in the plasma renin activity, angiotensin II levels, increase in mean arterial pressure, renal plasma flow, urinary ammonia excretion. So everything related to ammonia has improved in both the groups, but the encephalopathy has not improved in one group, which has been treated with colloids, and the other group. So this clearly demonstrates that ammonia is not a great marker. And any guesses who is the author for this study? So, ammonia levels continue to remain high despite resolution of ascites and rarely normalize. Another study showing the same conclusions. Professor Jas Bajaj, 2024 CGH, clearly demonstrated no relationship between serum ammonia levels and overt hepatic encephalopathy severity or time to overt hepatic encephalopathy resolution. What are the problems with ammonia measurement? Let's go take a little different path. So if you take 20 grams of protein in a healthy volunteer, the ammonia levels will increase. Sorry, in cirrhotic patients, the ammonia levels will increase, whether they develop encephalopathy or not. There's a difference when you measure ammonia levels in a fresh sample as compared to a thawed sample. Ammonia is not determined only by liver. There are several other organs which contribute, and this interaction is extremely important. In fact, while I was preparing for this, I realized that even in patients with COPD, the ammonia levels can be high. And that's very interesting because when Professor Kamath talked about labeling somebody as minimal hepatic encephalopathy, and if they have a sleep apnea or if they have a COPD, whether it is really hepatic encephalopathy or it is something else, because ammonia levels can rise even because of a COPD. And that's why if you look at the guidelines, the three guidelines which I'm quoting, the INASL shows increased blood ammonia alone does not add any diagnostic, staging, or prognostic value for HE in patients with chronic liver disease. A normal value calls for diagnostic reevaluation, which is exactly what Dr. Jalan also showed in his slide as the INASL guidelines. And the Asian consensus also said the same thing. It just added that isolated ammonia level increases without accompanying clinical signs or symptoms of HE should not alone be an indication for clinical therapy. The site of collection also is important. This study, which I found 1963, as almost 60 years ago, demonstrated that there will be a variation depending on which site you have collected the blood from. whether it is from the femoral artery, the median cubital vein, femoral vein, or a subcutaneous vein. They are all different. They are not similar at all. So huge variation depending on where you're collecting from. What is the ideal way of collecting ammonia? Fasting, minimum 12 to 14 hours. Tube should be filled completely. There should be no air pocket inside. It should be placed on ice immediately after collection. The tube itself should be pre-chilled, ammonia-free, and lithium heparin or EDTA. Now, this is fine when you are living in a country which has got sun exposure for maybe around 24 hours in a year total, whereas we have ambient temperature which is in the range of 45 degrees to 50 degrees for almost 4 months of the year. Becomes really logistically challenging. Processing, you have to separate the plasma within 15 minutes. For the patient, do not clench the fist. Transfer, use the plastic transport tube before freezing, and you have to avoid exposure to multiple other things, including glassware. The patient should be not smoking for at least 9 hours before testing. That again can be very challenging at times. And transport on ice to the lab immediately. So these are all logistic challenges, both in handling ice availability, delay in the processing, the 15-minute deadline, fasting protocols, smoking protocols, availability of pre-chilled tubes, the venipuncture difficulties leading to hemolysis. I mean, we all know how thin and fragile the veins of our patients can be at times, how that would lead to reliability. Then whether we can use central lines if they are there in the patients who are admitted, or capillary samples, we don't know. Then you have infrastructure gaps, because when you're talking of doing something for a large scale of population, it should be easily available. Do we have the cold chain infrastructure? I don't know. And similarly, the cost and accessibility versus the benefits that you gain out of it, I think are also quite challenging. And I come back to this paper from Just Bajaj, American Journal of Gastroenterology 2019, which showed the variability and lability of ammonia levels in healthy volunteers and patients with cirrhosis. And you see that there's a huge variation even in healthy volunteers in terms of plasma ammonia levels being, in fact, high in a proportion of healthy volunteers as well. And the difference in the levels from when they're collected from different sites and the different upper limits of normal by the different labs. So is ammonia useful at all as a biomarker? Probably it is okay to exclude another cause of, to exclude hepatic encephalopathy if it is normal in a patient with advanced encephalopathy. It may be a supportive thing for clinical diagnosis of HE, but no correlation with severity, does not affect treatment decisions, no correlation with resolution of HE, expensive, and has logistic challenges. So it almost started off with a New Year resolution, which we all take, where we have the expectations. But I think when we really put it to the reality test, this is what we get. Thank you very much.
Slides again, please. Okay, so I guess I've got a couple of minutes for rebuttal. How long? 5 minutes is it? Is it a rebuttal time or not? Oh, sorry? No, it's okay.
We can sabotage it.
Sorry, I thought there was a rebuttal.
No, you can. You should.
Yeah. Okay. So look, I think the important point that is made is very well about measurement of ammonia. And I think that I just want to sort of point out, Akash, that we've just written an article which is in the, just hang on, let me just move to the actual one, which is very simple. Even for you to collect ammonia levels will be really easy. Okay, so Venus, NE is okay. 4 hours fasting is fine. You need to obviously get to the lab on ice, and I'm not sure that this whole analogy about 45 degrees is a good one. How much alcohol is consumed in this country with the whiskey, we all know. So getting some ice is not a problem to get it to the lab. We just need to leg it down. Expensive? No, I think it's really important because expense we throw away. It costs in the UK £12, whereas to do a full blood count costs £10. So how many times do we do a CT scan in a patient with HE, which costs £600 in an emergency? So this costs us £12 to do. I'm not sure what it is in the US. So expense is really not the problem. The second point I just want to make is that the papers that are referred to by Akash are either retrospective, small sample sizes, seriously biased, poorly controlled, and not prospectively taken. There's not a single study that is shown you today, apart from Jazz's study showing that measurement of ammonia, the timing, where you do it is very important, which is actually illustrated on this slide. So, and that is exactly why the data I've shown you today in over 5,000 or 7,000 prospectively studied patients, properly collected ammonia levels show incontrovertibly that hepatic encephalopathy, ammonia is an important biomarker not only for diagnosis, but for defining response to therapy, to predicting which patients are likely to develop overt hepatic encephalopathy, all liver-related complications and mortality, which performs better than all three MELD scores that we have heard today. It contains only clinically and biochemically relevant measurements, and these are prospectively collected, prospectively validated in over thousands of patients. So I think, we can talk about it and we can debate it. You have to go with the data, not the opinion. And I think that looking at the quality of the studies that I've shown you today needs to be weighed against the quality of the studies that Akash has shown you. And with the caveat that you have to measure a biomarker properly in order to determine its value. The paper that he showed you about Don Rocky is really a reflection of the poorest way that you can measure ammonia. There is no mention of where the ammonia was collected, how was it measured, how was it transported, and what is reported in the literature. In fact, I'm not sure whether you read the paper, Akash. Did you read the paper? So I'm not going to stand you up on it. But we wrote an article to that which is called Erroneous Measurements of Ammonia is Going to Lead to Erroneous Conclusions, which was actually rejected by American Journal of Gastroenterology as a letter to the editor. So we had to publish that letter in the Canadian Journal because of the bias of the editor who had published that paper in the first place. So they did not accept my letter to Don Rocky's paper, which you quote today. And it had to be published as an opinion in another journal. So fundamentally, I think quality, 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 and let's get away from opinion and focus on data, data, data. Thank you.
So thank you. I think you almost convinced me once again with your rebuttal. I think talking of conflict of interest, you did not declare that you were the founder of the Ammon Society when you started the debate. I think that is the biggest conflict of interest. I think your next 20 papers, 5 conferences, and maybe 10 deals are going to be based on what you're debating today. So I think that's a huge conflict of interest. So, and I think thank you for saying that the papers which I quoted were of poor quality. I think one of them was definitely yours. So I think point well taken. I think I leave it to the learned audience here to take the final decision. But all said and done, I enjoyed preparing and delivering this debate. It's an honor to debate with you on this topic. Thank you.
With this, we come to the end of this session. Thanks to speakers and my co-chairs.
Question here. We all know cirrhotics, the ammonia will be variable because of gut flora, because of the scent, because of the functioning hepatocyte, because of the mass. So obviously direct correlation will not be valuable. In your own study in Tranas, followed by the Austrian and Georgian study, therefore, irrespective of venous or arterial ammonia, which you have used in the multicentric study, you have used a ratio. I think that should be emphasized because there is a laboratory variation, which I think Akash also missed. The ratio of ammonia, your lab value and exact value, where you can stratify this group, which the Austrian study has shown, and clearly we can correlate. That's a very important paper. I thought that would be.
Thank you so much.
Thank you.
Thank you for bringing that.
We're running short of time, actually. Okay, sir, Pekina, please go for it.
Dr. Jalan, you quoted many studies. However, most of your studies, I mean, at least two main studies, depicted data on acute on chronic liver failure, not on chronic liver disease per se. And I tell you, in chronic liver disease, there must be not 10, 20 studies which have shown ammonia levels may be high, unchanged, or even low in patients with encephalopathy. No correlation at all. And whatsoever you showed is your model, but how all clinical studies are against that. Second thing, you are talking of serum ammonia levels, say extracellular fluid. In extracellular fluid, that is by doing AV shunting, the blood which is coming from brain directly, the arteriovenous difference of ammonia has been measured, and it is same. I mean, it is encephalopathy, without encephalopathy, with the MHE is almost, there is no difference actually. Therefore, ammonia has not been implicated. Another thing, we did out 4 or 5 studies of treatment of MHE in combination with ammonia lowering agent and other agents like anti-inflammatory or binding endotoxins. We saw percent reduction in ammonia. Delta change in both the groups was similar. However, the group which received anti-inflammatory or drug binding endotoxins had more improvement, a higher rate of recovery, and also more improvement in grades of encephalopathy. If you think ammonia is so important, then ammonia reduction was same in the both groups. However, encephalopathy rate improved more in the patients who had reduction in TNF-alpha, interleukin 1, 6, 23, and endotoxins. How do you implicate these 3-4 queries I had?
Yeah, so I think we have to finish, and we can probably debate this outside.
Thank you so much.
But Dr. Sharma, I just want to tell you. I want to tell you that remember that you know the response of ammonia to the organ varies from person to person. So, for instance, an ammonia of 60 can produce encephalopathy in a cirrhotic, whereas in acute liver failure, you'll need a higher level of ammonia. Anil is also here. He sees patients with urea cycle enzyme disorders walking around with ammonia levels of 300, and they're okay. But if you saw that in a cirrhotic, they would be far dead with large cerebral edema. And the point is that we have to understand that the response of ammonia is context dependent. So therefore, the absolute amount of ammonia does not really determine an outcome for a group of patients, but it's important for an individual patient. And this is the point that Patrick was making earlier. It's not a ranking tool, it's a calibration tool. And the day I think the community understands that role of ammonia, I think we'll start to use it for personalization of care and personalization of biomarkers to our patients. I don't have the time to go into it today, but if you read the paper that I quoted in my first slide by Chris and myself, we identify this issue that we think about response of ammonia to an organ, or the response of the brain to ammonia, which is context dependent. So thank you
so much. Since we are
ammonia in brain, extracellular versus intracellular concentration. What do you think? Extracellular ammonia is more important, or intracellular ammonia is more important in determining severity, occurrence, and prognosis of hepatic encephalopathy?
So look, I don't have enough time to go into it just now, but the point is, it is not a simple answer. It's
very simple
Thank-
because
well, it's not simple.
the answer you have given in an article in which Dr. Rajiv Janan was only single author. He has published that.